As we illustrated during our journey through the adrenal gland, the adrenal cortex is composed of 3 layers. The outer zona glomerulosa, which produces mineralocorticoids, the zona fasciculata, responsible for glucocorticoid production, mostly in the form of cortisol, and lastly, the innermost zona reticularis, which produces androgens. Well, it's time to revisit that middle layer, because the signs and symptoms of Cushing's syndrome are a direct result of excess glucocorticoids. Many cases of Cushing's syndrome are caused by either an overstimulated adrenal or a productive tumor inside the adrenal. The most common cause of Cushing's, however, is probably exogenous glucocorticoid administration, as millions of Americans are given pharmacologic doses of steroids each year. Okay, as you by now know, at Sketchy, our recurring symbol for glucocorticoids is that eerie moon face. Just staring. Creepily breaking the fourth wall, as usual. It's meant to remind you of the classic moon faces associated with excess steroid exposure. And in this scene, we've painted it on the side of the lunar lander. That's right. We're going back to 1969. Woodstock is just around the corner. The BBC is about to air the very first episode of Monty Python's Flying Circus, and 2 men by the names of Neil and Buzz have just decided to jump down from their spaceship 200,000 miles from home. See that big pillow they prepared to help create a nice soft landing? A big cushion is our recurring symbol for Cushing's syndrome, which encompasses the most severe complications of glucocorticoid excess. Because iatrogenic Cushing's is so common, we'll start our story there. As the lunar lander Exogenesis 1 touches down on the moon's surface, think of it as a metaphor for exogenous glucocorticoids entering your patient. Exogenous steroids act in much the same way as your body's natural cortisol. So expect it to provide the same kind of negative feedback onto the hypothalamus and pituitary. That results in decreased corticotropin-releasing hormone from the hypothalamus, as well as decreased adrenocorticotropic hormone, or ACTH, from the pituitary. Low ACTH is represented by that ACTH clapperboard, broken and falling out of Neil's unzipped pack. Guess he had some filming duties later. No ACTH means that the adrenal gland doesn't get the signal to make its own cortisol. The bulk of the adrenal cortex is dedicated to glucocorticoid production, actually. So without stimulation from ACTH, the adrenals begin to atrophy from non-use. That's where use it or lose it came from. True story. Imagine that those little moonstones tumbling to the lunar surface are shriveled atrophic adrenal glands. All right, so we have all these glucocorticoids floating around causing Cushing syndrome. What does this mean for the body? The most common symptom is obesity, the pathogenesis of which is multifactorial. Part of it involves the ability of glucocorticoids to increase blood sugar levels and impair insulin function. This leads to a state of chronic insulin secretion. Insulin, remember, is normally responsible for bringing all that sugar back into cells. Well, insulin also promotes lipogenesis, or fat storage. And in the setting of Cushing's, fat is classically distributed around the trunk with sparing of the extremities, as depicted by the O2 tank malfunction over here, filling the truncal region of the spacesuit with air. Over time, fat deposits develop in other central areas of the body too, leading to the classic moon faces and buffalo hump appearance. All right, let's talk a little more about blood sugar. Glucocorticoids increase gluconeogenesis from the liver, illustrated by Buzz over here, as he pulls out sugary candy-coated moonstones from that liver-shaped crater. This contributes to chronic hyperglycemia. Turns out, glucocorticoids themselves can also indirectly interfere with insulin receptor signaling at peripheral tissues, which leads to insulin resistance and type 2 diabetes. At Sketchy, insulin is represented by a welcome inside mat, emphasizing its role in bringing glucose and nutrients inside the cell. This time, however, the door is giving us a little resistance. And remember that central adiposity? Obesity itself can contribute to insulin resistance. A whole nother complicated topic in itself that we'll cover in our diabetes sketch. All in all, we've got some prime conditions for the development of type 2 diabetes. Patients with Cushing syndrome may even show some of the classic signs of hyperglycemia and diabetes, including glycosuria, polyuria, and polydipsia. Another common finding in Cushing syndrome is hypertension. And while pathophysiology is only partially understood, we'll go over a couple main mechanisms that play a role. It turns out that glucocorticoids have some intrinsic mineralocorticoid activity, hence the large mineralocorticoid mineral crystals in the back there. Think back to our hyperaldosteronism sketch, where we discussed how aldosterone, the body's mineralocorticoid of choice, acts at the distal nephron to increase sodium absorption and volume retention. Well, at high enough concentrations, glucocorticoids start to exert the same effects. Glucocorticoids also increase cardiovascular sensitivity to catecholamines. In simpler terms, that means when vascular smooth muscle cells see epinephrine or norepinephrine, instead of going, they go, which, in slightly less awkward and more intelligible terms, just means that the vessels are more easily constricted when stimulated. Lastly, glucocorticoids also increase angiotensin production, the pressor effect of angiotensin II, and even the number of angiotensin II receptors. Needless to say, all of these effects culminate in some major vasoconstriction and increased systemic vascular resistance. Treatment of hypertension in a patient with Cushing syndrome is not much different than treating your regular old primary hypertension patient. However, one drug to keep in mind is spironolactone, an aldosterone receptor blocker. In patients with high levels of cortisol, this agent may be particularly effective because it allows you to inhibit that extra mineralocorticoid effect I mentioned earlier. ACE inhibitors and ARBs can be pretty effective too, because they interfere with all that weird angiotensin II stuff mediated by cortisol. Moving on. Glucocorticoids have a potent catabolic effect on, well, almost everything it seems. For example, catabolism of collagen in subcutaneous tissue leads to striae formation. Striae are kind of like stretch marks on steroids, and are especially common in areas of weight gain, like the abdomen, thighs, and buttocks. Striae may develop a purplish hue from rupture of small capillaries under the thin skin. Keep in mind that this same effect can be seen with long-term use of topical steroids, so easy on those creams, okay? Glucocorticoids also promote the catabolism of muscle, especially those fast-twitch type 2 fibers. Patients often fatigue easily and have trouble doing things like lifting out of a chair or lifting things over their heads, or simply righting oneself while wearing a heavy spacesuit. Okay, that's enough, Brayden. You're embarrassing yourself in front of Neil. Talk about the wrong stuff. As you can imagine, this weakness is yet another reason these patients develop skinny arms and legs in combination with the truncal obesity we discussed earlier. Alas, the bones aren't safe either. Cortisol increases bone catabolism, a process more commonly referred to as bone resorption. Bone breakdown is further perpetuated by decreased intestinal calcium absorption and decreased calcium reabsorption by the kidneys, all of which can lead to osteoporosis. Glucocorticoids are potent immunosuppressants as well, likely due to their effect of inhibiting cytokine synthesis and release, which blocks all kinds of B and T cell stuff. Not only that, research has shown that it probably involves some kind of ancient druid magic. This is illustrated in way more detail in our farm course, so go check it out. For now, just focus on this injured astronaut here, limping along with those crutches. Our recurring symbol for immunocompromised states. Expect patients with Cushing syndrome to have increased frequency of infections and impaired wound healing. Also, you see those lunar EMTs chasing after him? First responders are a recurring symbol for neutrophils, and we've brought them into the scene to remind you that both exogenous and endogenous glucocorticoids can increase the circulating neutrophil count. Part of this is due to the demargination of neutrophils, which just means that more are in the peripheral blood and less are stuck to the endothelial surface. Don't let that elevated white blood cell count fool you, though. Despite the high number of circulating neutrophils, these patients are still at increased risk of infection due to impaired B and T cell function. A majority of patients with Cushing syndrome also suffer from psychiatric disturbances, including depression, anxiety, irritability, and labile mood. And finally, to complete our picture of Cushing syndrome, take a look at the astronaut up on the moon base, doing some repairs. That falling gardener's hardware bag is meant to evoke an image of inhibited GnRH release from the hypothalamus. This, in turn, diminishes the amount of FSH and LH coming from the pituitary. As a result, women with Cushing syndrome often present with menstrual irregularities, or even amenorrhea. And there you have it. Cushing syndrome in a nutshell. As we discussed earlier, the most common cause of Cushing syndrome is treatment with exogenous glucocorticoids, such as prednisone and dexamethasone, represented here by the lunar lander Exogenesis 1. As a result of negative feedback on the pituitary, patients will have low ACTH levels, which over time leads to bilateral adrenal atrophy. Well, hold on to your space helmets, kids, because we're moving on to the causes of endogenous Cushing syndrome. The most common cause of endogenous Cushing syndrome is an ACTH-secreting pituitary adenoma. depicted here by that pituitary-shaped pack brought along by the film crew. Again, that action clapperboard is our recurring symbol for ACTH. In the case of an ACTH-secreting pituitary adenoma, the pathology is now termed Cushing's disease instead of syndrome, and is most often due to a pituitary microadenoma, which means it's less than 1 centimeter in diameter. Affected patients are typically women between the ages of 20 to 30. All right, so what have we got here? Lots of ACTH from the pituitary means lots of stimulation of the adrenal cortex, and therefore an overproduction of your body's natural cortisol. This is referred to as ACTH-dependent Cushing's. Also, you see those 2 huge adrenal-esque moon rocks? Because of constant stimulation from ACTH, over time, the adrenals undergo hyperplasia. In order to make all this ACTH, the body produces a molecule called pro-opiomelanocortin, or POMC for short. Back in our Addison sketch, this was symbolized by the POMC palm tree. POMC is a large peptide precursor, cleaved to produce both ACTH and melanocyte-stimulating hormone, or MSH. MSH goes on to stimulate melanocytes and cause hyperpigmentation. So, in the setting of ACTH-dependent Cushing's, remember that increased ACTH production goes hand in hand with increased MSH production. The resulting hyperpigmentation classically shows up on sun-exposed areas, such as the face and neck, or trauma-exposed areas, including the elbows and knees. In this scene, it's depicted by the pigmented moon mud splashing all over the film crew. Hyperpigmentation is a big clue that you're dealing with an ACTH-dependent Cushing syndrome. Remember, patients with exogenous Cushing's due to steroid administration will have decreased levels of ACTH, and therefore will not show signs of hyperpigmentation. All right, one more feature of ACTH-driven Cushing's that needs mentioning, and that's hyperandrogenism. Turns out that ACTH doesn't just stimulate